Once again, it's a great day now. Again, this is your professor in microbiology for our special class. It's Dr. Benjamin Cabrera. Well, today's lesson is about aerobic spore-forming and anaerobic spore-forming bacilli. So let's begin. Okay, so we'll start with the spore-forming bacilli. So the classic examples of this one would be your Bacillus and Clostridium species for the gram-positive spore-forming bacilli. Usually these are ubiquitous and they may form spores and they can survive in the environment for many years. So that's how they survive, they form spores. Well, anthrax is caused by Bacillus anthracis, which are still important disease of animals and occasionally humans. And Bacillus anthracis is the major agent of bioterrorism and biologic warfare. While your Bacillus cereus causes food poisoning and occasionally eye or other localized infection. Your Clostridia has toxin-mediated diseases like your Clostridium tetani that causes tetanus, your Clostridium botulinum which causes botulism, your Clostridium perfringens which causes gas gangrene, and Clostridium difficile which causes pseudomembranous colitis. Okay, let's talk about your Bacillus species. Most Bacillus species are saprophytic organisms, and they are usually prevalent in soil, water, and air, and on vegetation, like your Bacillus cereus and your Bacillus subtilis. So your Bacillus species are large aerobic gram-positive rods, which usually occurs in chains. Your Bacillus can grow in food and produce an enterotoxin or an emetic toxin that causes food poisoning. So it is a enterotoxin, while your Bacillus anthracis causes anthrax, and your Bacillus anthracis is the principal pathogen for this genus. And for the morphology and identification of your aerobic spore-forming bacilli, usually the spores are located in the center of the non-motile bacilli. If ever you'll see them in a culture medium, your colonies of your Bacillus anthracis will have a cut glass appearance in transmitted light. Now let's talk on the Bacillus anthracis, which causes anthrax, which is the human infection. Usually anthrax are primarily diseases of the herbivores, like your goats, sheep, cattle, horses, and other animals, even rats, but these animals are resistant to the infection. Okay? Humans become infected accidentally by contact with the infected animal or their products. Humans will acquire this disease through the entry of spores through the injured skin, like your cutaneous anthrax, or rarely through the mucous membranes, causing your gastrointestinal anthrax, or by inhalation of spores, which is used in bioterrorism in your inhalation of anthrax. The spores germinate in the tissues and at the site of entry and growth of the vegetative organism results in the formation of a gelatinous edema and congestion. And later on, the bacilli spread via the lymphatics to the bloodstream, and they multiply freely in the blood and tissues shortly after and before the death of the animals. The polydiglutamic acid capsule is antiphagocytic, and the capsule has a gene. Capsule gene is on the plasmid. In inhalation anthrax, it's also called your Hus-Zoster's disease. The spores from the dust of the wool or hair or hides are inhaled. Then, once inhaled, it is phagocytosed in the lungs and transported by the lymphatic drainage to the mediastinal lymph nodes. So, in anthrax sepsis, the number of organisms exceeds. It is measured prior to that. It is 10 to the 7th per ml. Okay. So, the anthrax sepsis causes death. Not before that, the patient may suffer from hemorrhagic mediastinitis and sepsis, which usually is fatal and ends up to death. Okay. For the pathology for these aerobic spore-forming bacilli, so, well, in susceptible animals, the organisms proliferate at the site of entry and they rapidly disseminate and reach the bloodstream. However, in resistant animals, there will be massive accumulation of leukocytes. The capsules gradually disintegrate and disappear, thus the organism remain localized. So what are the clinical findings in humans? 95% of cases are cutaneous anthrax and 5% are inhalation. However, the bioterrorism event in the fall of 2001, if we can search for that, resulted in 22 cases of anthrax, wherein 11 are inhalation and 11 are also cutaneous. 5 of the patients with inhalation anthrax died. So the 16 cases survived. For cutaneous anthrax, the exposed surfaces initially will form pruritic papules in a span of 1 to 7 days or a week after the entry of the organism or spores through a scratch. So the papule resembles an insect bite. Later on, the papule rapidly changes into a vesicle or small ring of vesicles that coalesce, leading to the development of the black scar. Then lymphangitis and lymphadenopathy and systemic signs and symptoms like fever, malaise, and headache may occur. Usually 20% of patients with cutaneous anthrax can end up having sepsis. This is the consequence of systemic infection, which includes meningitis and later on ends to death. So the incubation period of the inhalation anthrax usually is 6 weeks. Early clinical manifestation would be marked hemorrhagic necrosis and edema of the mediastinum, and substernal pain may be prominent, and there is announced mediastinal widening which is visible on radiographic films. Hemorrhagic pleural effusion follow the involvement of the pleura, and later on, usually cough is just secondary to the effect of the organism and infection on the trachea. With sepsis, there is hematogenous spread to the gastrointestinal tract, causing bowel ulceration and going to the meninges, causing hemorrhagic meningitis. The fatality rate of inhalation anthracis high in settings of known exposure. For diagnosis, diagnostic test, so we can get samples out of the fluid or pus from a local lesion and blood and sputum. And in microscopy, you can identify large gram-positive rods, and they, when grown on blood agar plates, the organism produces a non-hemolytic gray to white colonies with rough texture and a ground glass appearance. That's the cut glass appearance, okay? And there will be comma-shaped outgrowths that may project to the colony, bearing the feature of a medusa head. So there are only 4 countries that can produce the vaccines for anthrax, namely Russia, China, US, and Great Britain. Foreign, because they develop it because these are anthrax is still a potential biologic weapon. Now, the military is developing new recombinant protective antigen vaccine against anthrax. For the treatment of anthrax, the drug of choice is quinolone, which is your ciprofloxacin. However, previously, a combination of penicillin, yerpenicin, and gentamicin or streptomycin have been used. So it's a penicillin and aminoglycoside. That was the treatment before, but the drug of choice is ciprofloxacin. Potential exposure of your Bacillus anthracis as an agent of biologic weapon, so we can use prophylaxis with Cipro or Doxy for 4 weeks, while 3 doses of vaccines are given, or for 8 weeks if no vaccine is administered. For epidemiology, prevention, and control of your Bacillus anthracis, soil is usually contaminated with anthrax spores from carcasses of dead animals. However, these spores remain viable for decades, so thus grazing animals can be infected through injured mucous membranes, and they will penetrate the skin of the animals or the mucous membrane of the animals and perpetuate the chain of infection. Contact with the infected animals or with their hides, hair, bristles is the source of infection in humans. There are control measures that have been in place, like disposal of animal carcasses by burning, or by deep burial in lime pits, or by decontamination by autoclaving of animal products, use of protective clothing and gloves for handling potentially infected animals, and active immunization of domestic animals with live attenuated vaccines. Now let's move to another topic, which is your anaerobic spore-forming bacilli. Remember, your aerobic spore-forming bacilli would be your Bacillus species. Now let's go to the anaerobic spore-forming bacilli, which is your Clostridium species. So your Clostridium species are anaerobic, gram-positive motile rods, and many decomposed proteins form toxins. The natural habitat of your Clostridium species would be the soil or the intestinal tract of animals and humans. And in humans, they are saprophytes. And the pathology or the diseases that it causes would be botulism, tetanus, gas gangrene, and pseudomembranous colitis. So they have spores which can be centrally, subterminally, or terminally located. Most species of Clostridia are motile and possesses Pterygochus flagella. They usually will live in anaerobic conditions because they are anaerobic spore-forming bacilli, so they will be requiring anaerobic conditions, especially in the culture. And Clostridia can ferment a variety of sugars and can digest many proteins. In a milk media, it can have stormy fermentation. That is, they form clot which are torn by gases. With the third group, that is your Clostridium perfringens. Now let's discuss further the first organism among the anaerobic spore-forming bacilli. Let's talk about your Clostridium botulinum, the main causative agent of botulism. This organism is usually found in the soil and animal feces, and they have 7 antigenic varieties of toxin labeled from A to G, and the usual toxin that causes illnesses in humans would be your types A, B, E, and F. Your types A and B have been associated with a variety of foods, and type E are predominantly found in fish products. Your type C produces limber neck in birds, and type D causes botulism in mammals. How does Clostridium botulinum causes problems? Okay, the condition that it causes is botulism, or the disease that it causes is botulism. It results from intoxication from the ingestion of food in which your Clostridium botulinum is grown and produce the toxin. So it's a toxin that causes a problem. Most common food that are involved will be your spice, smoke, vacuum packed, or canned alkaline foods that are eaten without cooking. Toxin acts by blocking release of your acetylcholine at synapses and neuromuscular junction. Your botulism manifests as flaccid paralysis. It is usually seen in your electromyogram, and your endroponium strength tests usually are positive. So, what are the clinical findings with the infection of your Clostridium botulinum or your botulism? The symptoms usually will occur 18 to 24 hours after ingestion of the toxin, manifesting as visual disturbance like incoordination of eye muscle, double vision, inability to swallow, and speech difficulty. There can be signs of bulbar paralysis, which later on will be progressive, and death can usually occur due to respiratory paralysis or cardiac death or cardiac arrest. GI symptoms usually are not prominent. In this infection, there is no fever. Thus, the patient remains fully conscious before the patient dies. The mortality rate is high among infants. The infants in the first months of life develop poor feeding, weakness, and signs of paralysis, labeled as your flappy baby. Infant botulism may be one of the causes of sudden infant death syndrome. With this, honey, which are usually given, are the possible vehicles for the spores. Then, toxins can be demonstrated in the serum from the patient, and toxins can be found in leftover food. Mice injected with the toxin intraperitoneally will die rapidly. In infant botulism, your Clostridium botulinum and toxin can be demonstrated in bowel contents but not in the serum. Toxin may be demonstrated by passive hemagglutination or radioimmunoassay. So treatment, there's an available potent antitoxin to the 3 types of botulinum toxins. These are all prepared from horses. In management, there should be adequate ventilation, and the patient can be subjected to mechanical respirator, which can reduce the mortality rate from 65 to below 25%. Most infants with botulism recover with supportive care alone. Antitoxin therapy is also recommended. Okay. Spores of Clostridium botulinum are found in soil, contaminated vegetables, fruits, and other materials. The chief risk factor for botulism would be home canned foods like your string beans, corn, peppers, olives, peas, and smoked fish or vacuum-packed fresh fish in plastic bags. Toxic foods are spoiled and will be spoiled and smell rancid. And look at this, the cans may swell. Or fortunately, appearance may be innocuous. This from home canned foods can be reduced if the food is boiled for more than 20 minutes before consumption. Your botulinum toxin is also used as a major agent for bioterrorism and for biologic warfare. And again, okay, before we go to your Clostridium tetanus, but Clostridium botulinum toxin are cosmetically used in cases of, that's one for cosmetics. If you know your Botox, actually your Botox is Clostridium botulinum toxin. That's Botox botulinum toxin. So these toxins are harvested and injected to paralyze the muscle in the face. You can have toxic paralysis. So there will be no contraction of the facial muscle. So the patient's face can be expressionless. Okay, now let's proceed to another genus of your Clostridium, which is your Clostridium tetanus. It's much well known. It causes tetanus. The vegetative cells of your Clostridium tetani can produce the toxin, and this toxin binds to the receptors of your presynaptic membranes of your motor neurons. Okay, the toxin degrades your synaptopridine, which is a protein required for docking of your neurotransmitter vesicles on the presynaptic membrane. Thus, the release of your inhibitory glycine and your aminobutyric acid is blocked, and the motor neurons will not be inhibited. Thus, it causes hyperreflexia, muscle spasm, and spastic paralysis. Okay? Extreme small amounts of toxin can be lethal for humans. So, for Clostridium botulinum, it is flaccid paralysis, but for Clostridium tetanus, it is spastic paralysis. However, your Clostridium tetani is not an invasive organism. Infection usually will remain localized in the area of the devitalized tissue, like in your burn wound, deep wound, your umbilical stump, and surgical sutures to which the spores have been introduced. Then germination of the spores and the development of your vegetative organism that produce the toxins are aided by the following: your necrotic tissue, the presence of calcium salts, associated pyogenic infections, and all these three will aid the establishment of low oxidation reduction potential and encourages the vegetation and multiplication of your Clostridium tetani. Then toxin is released from your vegetative cells and reaches the central nervous system and rapidly becomes fixed to the receptor in the spinal cord and into the brainstem. Incubation period for your Clostridium tetanus is around 4 to 5 days, and in some cases it is reported as many weeks. This is characterized by tonic contractions of your voluntary muscles, so your skeletal muscles. So there will be tonic contractions and resulting to muscle spasms that involves first the area of the injury and infection, then the muscle of the jaw. That's what we call your trismus or lockjaw, wherein the mouth cannot be open. Voluntary muscles becomes involved and there will be tonic spasms. Any external stimulus may precipitate a tetanic generalized spasm. Any external stimulus can precipitate a tetanic generalized muscle spasm. The patient is usually fully conscious, but the pain can be very intense. That usually results from the interference with the mechanics of your respiration. The mortality rate in generalized tetanus is usually very high. So, diagnosis, okay, usually is can be done through the clinical picture and history of injury, and 50% of patients with tetanus have an injury for which they seek medical attention. Differential diagnosis for tetanus will be your strychnine poisoning, wherein your strychnine is a plant alkaloid. This is used as a rodenticide. It presents with generalized seizures but no localized or extensor poisoning or rhizus sardonicus. So there is no localized posterior posturing or rhizus sardonicus, which is usually seen with your tetanus. So extensor posturing, so the back, in patients with tetanus, there will be spasm of the vertebral or the back muscles, causing extension of the back. And rhizus sardonicus is the contraction of the facial muscle, forming a green-like joker. Anaerobic culture of tissues from contaminated wounds may yield your Clostridium tetani. Well, prevention is all important. You can do 4 preventive steps like active immunization with your toxoids, the proper care of wounds that are contaminated, usually especially those contaminated with soil, the prophylactic use of your antitoxin, and administration of penicillin. Your antitoxin can be given intramuscularly with a dose of 250 to 500 units. Your antitoxin is tetanus immune globulin, and this will neutralize the toxin that has not been fixed to the nervous tissue, meaning those free-flowing toxin that is still not fixed to the nervous tissue. Active immunization with tetanus toxoid should accompany antitoxin prophylaxis. Patients with symptoms of tetanus should receive muscle relaxants. They should be sedated, and assisted ventilation should be done. Sometimes they are given very large doses of your antitoxin, as high as 3,000 to 10,000 units of tetanus immunoglobulin for symptomatic patients. But for For prevention and prophylaxis, you only give 250 to 500 units, but for those asymptomatic, you give 3,000 to 10,000 units of your tetanus immune globulin. Surgical debridement is very important because it removes the necrotic tissue that is very essential for the proliferation of the organism. Sometimes there have been studies that have recommended hyperbaric oxygen exposure, but later on it was disproved. There is no proven effect of your hyperbaric oxygen. Penicillin strongly inhibits the growth of your Clostridium tetani, which further stops the production of toxin. Okay? Previously immunized individuals sustains a potentially dangerous wound. An additional dose of toxoid should be injected to re-stimulate your antitoxin production and accompanied by a dose of your antitoxin if the patient had not had current immunization or boosters, or if the history of immunization is unknown. So, how to be controlled it? There is the 3 injection, okay, for immunization. There is 3 injection, followed by another dose 1 year later on. Initial immunization should be carried out in all children during the first year of life. So the first 3 doses, it is included in your DPT. A booster injection of toxoid should be given upon school entry and can be given later on 10 years apart, just to maintain serum. There would be your toxin-producing Clostridia, would be your Clostridium perfringens and other related Clostridia, which can produce invasive infection, including your myonecrosis and gas gangrene if they are introduced into damaged tissues. Most common in invasive disease is your Clostridium perfringens, which comprises 90% of cases. Remember, your Clostridium tetani is non-invasive, but your Clostridium perfringens is invasive. An enterotoxin of your Clostridium perfringens is a common cause of your food poisoning. Your Clostridium perfringens food poisoning usually follows the ingestion of large number of Clostridia that has grown in warm meat dishes. Toxin forms when the organism sporulate in the gut, and there will be onset of diarrhea without vomiting or fever. That occurs 6 to 18 hours post-injection. So if ever you have diarrhea 6 to 18 hours after eating warm meat, that could be the cause. Clostridium perfringens. The illness usually lasts for 1 to 2 days. Usually, to diagnose this one, materials is inoculated into chopped meat glucose medium and thioglycolate medium, and then later on into the blood agar plates incubated anaerobically. The growth of one of the media is transferred into milk, and there will be clot torn by gas or stormy fermentation. Will occur in 24 hours. Is suggestive of your Clostridium perfringens. The final identification rests on the toxin production and neutralization of specific antitoxin. Your Clostridium perfringens readily produces spores when cultured on agar in laboratory setting. So how do we treat? The most important aspect of treatment is prompt and extensive surgical debridement of the involved area and excision of all the vitalized tissue in which the organism can be prone to grow. For your anaerobic, that's for your tetanus. Then you can give penicillin. Antitoxin are available against toxins of your Clostridium perfringens, Clostridium lovii, and Clostridium histolyticum, and Clostridium septicum, usually of concentrated immune globulins. Food poisoning due to Clostridium Perfringens and tetrodotoxin usually requires only symptomatic care. So just hydration and let it flow. Prevention and control, early and adequate cleansing of contaminated wounds and surgical debridement, together with administration of antimicrobial drugs directed against Clostridia, are the best available preventive measures. Let's talk about your Clostridium difficile, another diarrheal disease. Your Clostridium difficile is the cause of your pseudomembranous enterocolitis. These are pseudomembranes or microabscesses in patients who have diarrhea, okay, which have been given prolonged antibiotics. The diarrhea can be watery or bloody, and the patient frequently has abdominal cramps, leukocytosis, and fever. The causative antibiotic associated would be your ampicillin and your clindamycin. So the disease is treated by discontinuing these drugs and administration of metronidazole or vancomycin. It is the common cause of your antibiotic-associated diarrhea. The administration of antibiotics frequently leads to mild to moderate form of diarrhea, termed as antibiotic-associated diarrhea. They are less severe than classic form of your pseudomembranous colitis. 25% of cases of antibiotic-associated diarrhea can be caused by your Clostridium difficile. And that's it. We've done with your aerobic and anaerobic spore-forming bacilli. So in review, your aerobic spore-forming bacilli would be your Bacillus, okay, species, and your anaerobic spore-forming bacilli would be your Clostridium species. Once again, maraming salamat po. Thank you for subscribing. So don't forget to click that button, click that thumbs up, click that notification, and subscribe to my channel so that you can be updated whenever I'll be having another set of lecture. And have a great day.